You have facilitators at at each table, so either they or someone they have designated will give us a 1 to 2 minute report back. We need a little. It's hard to stop these fabulous conversations, but we're gonna start. Look at this as practice for tomorrow when you're going to be giving elevator speeches. So we're going to ask for an elevator speech answering these questions. To really, what we're trying to do is harvest these and build them into this community conversations that are going to continue. So this won't be the end of the conversation. So I'm going to take each table, just go around. I'm going to start here at our table. And Julie, you have an example and answering these questions 1 to 2 minutes.
Okay. Thank you. I'm Julie Pavlin from the Academies, and my example is something in a previous position where we had a mini course, a workplace mini course. So not just a one-off training, but a series of courses. This was once a week. It could be once a day over a week, whatever, how it works. But this was a mini course on use of geographic information service mapping, GIS mapping into like epidemiological studies. So this is teaching our epidemiologists how to use GIS. And so they benefit, the people who benefit are the epidemiologists, many of whom may have gone through training before this technology was available. And the other benefits downstream are, in this case, it was the military leaders who would get better geographic information on health information of where and who was having different health effects, and eventually, hopefully, the population health, if you could target, based on that information, target your medical services. So that's how they benefit. The cost is the cost of a person to come in and teach that course. In this case, it was a fellow military from the Uniformed Services University, so we didn't actually pay for it, but somebody paid for that person's time. So there is the cost of that. There's also the cost to the time that it took the epidemiologist to do the training. And the other is obviously cost. If you, in this case, there might be software costs or something like that if the institution is going to buy the software. And I also wanted to mention, I forgot to mention when I talked about the mini course, I think one thing really important is to have this be interactive. So we talked about other examples here, and the idea is homework, not really horrible homework, but something they actually look forward to doing, but something that keeps them engaged week to week, and that they have to do it on their own so that they come back and they're ready for the next time you meet. So do that in your course. So the incentives for paying for this are to obviously to improve the morale of your staff, because this is training that they may have wanted, and in this case we all did want it. So we get incentives for improving your morale, and obviously incentives in the long-term products that you can deliver. If we were tasked to deliver epidemiologic information on the health of our populations, so this improves that. So it incentivizes us to get that better information out. And then hopefully our bosses then see better health effects.
Great example. Population health, we've started talking about that, so that's a great one to start us with, Julie. Let's go back to this table here, and right behind us. Julie, is it Julia? Great. Mike.
This table basically talked about learning leadership skills and management skills, and there was a little bit of debate as to how those two things interfaced and related, which is possibly the reason that this is needed. And as far as who benefits from CPD, we talked about faculty, students, their colleagues, as well as the organizational culture, because the idea was to get skills and maintain those skills. As far as the management skills, sometimes they can be as basic as business plans, financial plans, communication, evaluation, and then on the management side, on the leadership side, really being able to inspire people and to go forward with a vision. And they stressed as well interprofessional teams, so that it wasn't just one group of people who always talk to each other, continuing to talk with each other. But instead, by having this kind of interdisciplinary, interprofessional, ecumenical kind of team, they could learn from each other and possibly gain some new respect for the different roles that people all played in the process. What is the cost? The cost is basically the delivery of the training, the opportunity costs, what has to shift in order to accommodate that kind of training, and what other cost? I think that covers it. Thank you.
Thank you. Very good. Excellent. Great. Two great examples so far. Let's come up to this table here.
All right, Joel Nelson from the Health Resources and Services Administration. I think our table had more of a theoretical and aspirational conversation.
Very good.
around this.
Thank you.
So bear with me. I'm going to pull our wide-ranging conversation into 1 to 2 minutes. So we focused on opioids, training around the opioid epidemic, and approached it from the ecological model that was just mentioned, really thinking about, why do we prescribe these medications, what are the practices leading to the prescription, dispensation practices, patient education opportunities, and then also identification and resolution of crises. And so thinking about all of those far-ranging concepts, focusing probably mostly on providers, the prescribers, as well as the point of dispensation, training around, what are the elements of pain recognition, non-pharmacologic interventions besides obviously the reason for these medications, and thinking about that, trying to address, how we prescribe, points of tracking and reporting of prescriptions, as well as HIT, using electronic health records, de-identified case studies to sort of break down examples for where the system works well, where it doesn't work well, what are the sort of ways people game the system in order to maybe achieve an end, and learning from those examples to empower the prescriber, to empower the dispenser, to empower the patients themselves, then to more responsibly engage in the entire system, to know the options available, to take the correct course of action where appropriate, and then to identify where it has gone wrong and maybe get back on track. And so I think the benefits are wide-ranging. If we focus on these providers, the benefit could be to, obviously, there's a public health benefit, the patient benefit. There's benefits to the providers and the prescribers and the dispensers feeling more confident in their skill, more confident in their decision and their approach. And then obviously systems benefits in terms of reduced public health costs, costs to health systems, public safety, all of those things.
Fabulous. We're talking about some really important problems and how CPD can address those. So thank you very much. Let's go back. Marilyn, do you have a report?
But I'm going to do it with help from the team.
Okay.
So I'm Allison Whalen from the AAMC. I'm going to talk about a case from my previous place. So in the high-risk OB section, they'd identified that there was a higher level of complications in conversion to C-section, so developed a simulation-based, team-based activity to practice the very specific high-risk conditions. So who benefited? The patients, the health system, in that it decreased the complication rates, and really the team, because they worked together and had shared best practices. What were the costs? In order to develop the simulation, needed to develop a single best practice, so that took time. Everyone had to take time out from the clinical work to participate in the simulation, and then the cost of both the training, the simulation, and then the debrief from that. And we thought the incentives were broad, that with the decrease in complications, it could increase reputation. I don't have the data. I know they looked at it, but don't have it. For the bundled payments, would decrease the overall costs. There is a perverse disincentive in that C-sections actually have a higher bundle rate. So if you decrease C-sections, you may be changing your revenue. And then for the system, because in our system, probably 10 to 15 to 20% of residents end up staying in the system, that you're beginning to build the practitioners for the future. So it's investing in your future as well. And then better team. So potentially a halo effect as the team goes back and does other work together. Thanks, Dad.
Great summary. Thank you. Lots of important information on that for the business case for those people who would invest. Thank you. Let's come up here to this front table. Is that Simon?
Simon Kitto, University of Ottawa. So our group wove a rich tapestry as well, drawing on principles and aspirational ideas around what we'd like to see happen in a certain area. So what we thought about was the use of clinical data for performance improvement, using that at an individual and team level as well as incorporating the patient experience in the design of a high-value CPD activity. So one of the examples we thought of was the use of team steps, which is normally in a hospital setting within, as applied to a palliative care context. But we also thought about expanding that out and using those principles in the home as well. So moving from the hospital base to the home setting in a palliative care situation. So in terms of who benefits, we talked about the payers, we talked about the family themselves, the increased communication, enhancement of communication, the community, the caregivers, and so on. In terms of the cost, it seemed to be a simple metric of calculating the cost of care in the home as opposed to the hospital, and seeing what that would look like. And I think one side would definitely look a little bit prettier than the other. In terms of payment incentives, one of them that we thought about, we didn't go into that too deeply, but one of them was in terms of pharmacy in relationship to the reduction in the use of narcotics, particularly when we're talking about end of life palliative care stage. So,
Great, thank you, excellent, terrific. We have so many good examples here. Well, let's go right behind you.
All right.
Sue?
So our table embodies disruptive innovation.
Excellent.
And insisted on challenging some of the premises before we could get to specific examples. And I think that it was clear that our folks wanted to assure that the goals were going to improve population health, including health professionals and caregivers as part of the population, and change the assumptions of in a way of professionalism away from the clinician as a high priest or priestess to one who's much more of a coach and facilitator in the process. They wanted us to be using both new instructional technologies, but also go back to basics in some ways in adult learning principles. So we've got some parameters by which we can now move forward.
Great. We need disruption. Thank you. Let me pop up to the table 7. I can't see who's over there.
Darlene Curley.
Okay, thank you, Darlene.
Thank you, of course. We looked at an actual example. We're a national association with thousands of clinics around the country, wanted to improve the competencies of administrators at each of the clinics. The benefit would be to the patients, the clients, the employees, the administrators themselves, and to the system. The cost was having an expert consultant, the platform for delivery of the education, and the time of the administrators. It started off, it seemed as a top-down kind of approach from the organization, but two things that were kind of aha moments for our group. One was that the learners took charge of this, which was a very exciting, I think, thing to happen to this group from what started as a top-down. And the second part of it was that they had no business case. So they just jumped in and started. They were the doing kind of group at a very large scale. And now they're going to develop their business case. And there are, you know, that can be a good thing, but it can be perilous. So.
Fabulous, thank you. We have a group in the back. Is that Don Moore? Thank you.
Thank you. We looked at ventilator-acquired pneumonia in a practice setting, an interprofessional continuing education activity. There was data-driven pre-work in the sense that we identified the problem through root cause analysis and identified the gap and the intervention. Brought the team together, started off with simulation, and basically did data-driven evaluation, in other words, data biopsy over time. So we focused on and reorganizing the innovation over time. So the educators had to take risks in terms of looking at being collaborative coaches, mentors, facilitators. The accreditors, we had 2 accreditors in our group, if you hadn't noticed, were challenged to remove barriers and allow innovation. The credit system and regulators were asked to value the learning and change, the learners to participate, respect, and expect more from each other, and the institution to invest in support. And basically, we thought that the benefits for patients would be their improved health. For the clinician would be a rewarding experience in being able to implement an intervention that actually improved the health of their patients. And obviously for the institution, in terms of bundled costs, the cost would be reduced in terms of implementing this VAP bundle.
Thank you, Don. Wide-ranging examples. This is great. Do we have just one more group in the back? Are we done? No? Okay. All right. So this has been very productive. We've entered a lot of examples of high-value CPD connected to outcomes into the community for us all to consider. And it is now time for that very important thing called a break, right? And 30 minutes. So we'll reassemble at 11:15. Okay, very good. We'll see you all shortly. Thank you.